Enter the room.
Hello, I'm Dr. Barfin. May I confirm your name, please?
Yeah, sure, doctor. I'm Carol Foster's. Yeah.
Yeah, hello. What brings you today here?
Doctor, I'm having very much pain in my left eye. It's so huge that I have to really cover it. Sometimes I use
Okay,
the glasses, but now I'm very much in pain that I have to cover it somehow.
okay. So when did this pain start?
Well, doctor, it started like 4 months ago. Sorry, I'm really sorry. So 4 hours ago it started, and it's now going to my left side of the head as well. So it's really pain.
Okay. Do you have any other symptoms with this pain?
Uh, yeah, I have headache, and I actually also was also feeling nauseous, and I did vomit once as well.
Okay. So do you have any other illnesses? Are you taking any medications for them?
Um, well, I was diagnosed with depression 6 months
Mm-hmm.
ago, and I do take Amytriptyline 25 milligram once it for that. So that's the only thing. And also I
Okay.
do suffer from back pain. So also it's been poking at me for like quite long. I'm just worried about this pain, doctor. It just makes me quite worried about this pain.
Okay. Okay. Do you have anyone in your family with this kind of pain before or eye problems?
No, not that I know of.
Okay. Okay, so I'm gonna perform an examination on your eyes now, if it's okay for you.
Sure.
Uh, so yes, so the examination won't be painful for you. I'm just gonna check your eye pressure and your eyes and do my examination now. Yes. Okay. Okay. So do you have any medication allergies?
No, no.
Okay. So do you have any ideas what might be causing that?
No, doctor, I'm just having so much pain that I'm even having difficulty, looking at you or like even keeping this conversation forward. So I'm really worried about the pain, and this vision as well is quite not so good.
Okay, so I'm suspecting open eye ankle glaucoma, so I'm referring you to our ophthalmologist for an urgent assessment and for pain medication.
What is that, doctor? What is that? I don't even understand that.
What we call is that it might be affecting your eye. There might be something changing in your eye pressure, causing that, or you might have something called uveitis. It also causes that pain. There is a part in your eye causing contracting your eye muscles, allowing you to see. And if it gets closed, it's causing your pressure building up there, and it's causing headache and nausea for you. So you need to be assessed urgently by an ophthalmologist. That's why I'm referring to you.
Oh, but doctor, do I have to stay in the hospital because I have kids? I'm married and I have two kids. I have to take care of them. So I really would like to go home, and I don't know what to do.
Yes, I definitely understand your concerns. However, it's quite an urgent situation and it might affect your eyesight in the long term. So you need to be assessed emergently, actually.
Well, that's quite a shock. I was suspecting that it might be something serious, but I didn't expect to be this serious, I would say.
Yeah. Yes, it's quite an emergent situation. Do you have any other concerns?
Yeah, well, I just like taken a bit back. Like I'm just concerned about what I will do with my kids and my vision as well. And how can this happen? Why would this happen? I don't understand.
It might causing by other diseases or even caused by your medications. It might cause that. So there are a lot of other reasons. So
So
that's why.
which is the reason here in this case of me? I would like to know this because
Probably due to amitriptyline take you're taking due to your depression. It might cause that. So that's why I'm referring you.
but I've been taking it for quite a long time. Why did it come now?
Well, there are some side effects that occur instantly, and some of side effects occur in long term. It might cause that.
Okay. And what else can I know about this? What should I do something else with regard to this condition?
Well, we're gonna start your medications for your nausea and for your pain, headache. In the meantime, while we are waiting for your assessment. However, in the long term, you need to be under constant observation of ophthalmologist, like follow up.
Follow up. Okay. All right. So I'm just thinking what I'm gonna do with my kids, because all right. If it's that urgent, I will stay. I will see what I can do.
Do you have any other person in your family who can take care of kids in the meantime?
Well, my husband, he's working now, so maybe I can call him and to explain the situation. So, and or maybe I should go by driving back because I came here by driving, and maybe I can go back to him and to explain it in person. Is that better? And then
No, actually, you cannot do that because your condition might deteriorate. So it will be better if you call him and tell him about the situation.
all right, all right. Okay, all right. So I will do that. And okay, thank you for your time, doctor.
Of course, thank you.
Right. Doctor, okay, good. So, do you have anything to say, Dr. Nevin, before we hand over to the examiner?
You did, I think, as you mentioned that this is the first time, right? I mean, you haven't
Yes,
even,
no.
right. So you will have to go through some way of, some formats to really get. When I talked about the pain, you had to ask a lot of attributes regarding the pain, the Socrates, right? The site, the onset, the character, the radiation, everything with
Okay.
relation to the pain, so that you get a better understanding of the pain, so that you can ask your differentials based on that. You haven't asked me any differentials to rule out other
Okay.
causes, so you would have to include those in your consultation after, because you have to be looking out for the red flags. One is glaucoma. The other things would be like a GCA, for example. You have to also rule out as given her age, she is 50 years old, and an eye pain that started suddenly. So this is a GCA that you have to rule out. You have to ask concomitant questions to arrive at a diagnosis, and also that will be from the part of gathering information, while the IPS would be to be more empathetic to the situation that was being done, because I was actually being anxious and I was actually showing my hand here to note, like I wanted you to notice that I'm having some discomfort, so you can actually verbalize that. I can see that you're holding your hands up, so would you like me to maybe dim the lights or do something for that, so that you can be at your ease when you're in the consultation? Does that make sense for you?
Yeah,
Because
yeah, yeah.
so this is actually more patient-centered, together with the not only the disease, but also you're taking the concerns and expectations about the patient. You can be more patient-centered. So this is from my part. So you could do, and in general to follow a structure, but not to adhere to it, but to have a to get you haven't gotten your informations to arrive at a diagnosis, so you have to do it in a systematic way. So I think by practice you can reach up there, but for your first time I would say it's quite good. So I will just move over to the examiner's comment.
All right. So our examiner is ready. So,
Hi, Dr. Buffin.
Hello.
So, how do you feel about your performance?
Well, I'm quite anxious because this is the first
Mhm.
time. So
That's
to
totally
actually,
fine. Yeah. So for
so
your first
actually,
time, yeah.
I don't know. Like, should I ask for the differentials to the patient?
Yeah.
Okay.
So I'll be telling you about giving you a brief idea about the structure and how this PLAB2 format goes. So you'll get an idea in your future cases, right?
Mhm.
So how you can handle those. But for your first time, it was really good. You understood the case, you got your diagnosis, but just the way it's put into, needs some changes. So we can work on that. That's okay. So in PLAB 2, we have three domains in which you'll be assessed. So which is data gathering, management, and IPS. And that is interpersonal skills. So all the three hold a very equal, weightage. Each has four marks, and it adds up to 12 marks. So we need to concentrate on each thing. And the most important thing first is your data gathering, because you tend to get easily, you can easily score marks there if you just ask all the questions. So
Mhm.
when you first start the case, you need to introduce yourself saying that I'm Dr. Burfin, I'm a junior doctor in the GP surgery, and my GMC number is so and so. So you need to say that, and you shall ask the examiner, shall I proceed? And then you go to the patient and you introduce yourself to the patient. You can say that I'm Dr. Burfin, a doctor in the GP surgery, and I'll be your consulting doctor today. So can I know your name? And the patient says, I'm Carol Foster. And you can ask the patient, may I know how can I call you? How do you like me to call you? And she might say Miss Foster or Carol, anything is fine. And then confirm her age. In this, I think you didn't confirm her age. So that is very important. So you just cut 1 mark for that and you just lose a major point there. So a name and age is very important. So once we confirm that the patient is done, so then the patient starts telling her complaints. So in this case, the patient told that she had a pain in her left eye, and when it goes to her head also. So we need to explore that a bit more. So there's a thing called Socrates in PLAB 2, which we follow, which is just if there's a pain, we use Socrates. Like, what is the site of the pain? From when did you get the pain? The onset of the pain. So how is the pain? For how long has it been? Does it go anywhere? Is it radiating? Is there anything which, helps it to make it better, or anything which is makes it worse? The severity and things like that. So when we explore that, we get a better idea about the pain. So in this case, the patient might say that, anything which makes it worse or anything, the patient might say that she has photophobia also, and that's the reason they're wearing glasses. So we need to just gather information. The patient won't tell us anything abruptly until we, persuade them and we ask them in detail. And then she also had a red eye. So for that, we do something called OD-para. It's the same thing like Socrates, but we do that the onset, the duration, the same aggravating relieving factors, and has she had anything like this before? So these are some things that we need to. This takes time, but we need to just do it quickly, without giving a pause. So we'll get an idea about that. And then we need to, in pain, whenever you see a case with a pain, you need to ask the patient to score the pain out of 1 to 10. So 10 being the highest and 1 being the lowest. So in this case, the patient would have told that she had a pain of about 9 on 10, which is quite severe, right? So it's alarming. So when she says that, we need to acknowledge the patient. So I can see that you're in so much of pain, it must be really difficult for you. So do you want me to give a painkiller, or are you comfortable to continue your consultation? So things like this will add up onto your IPS indirectly. So in PLAB 2, they mainly focus on patients comfortable, and is the patient feeling safe? Are they, feeling good? So that's what they mainly see. So I think we should concentrate more on that and make the patient feel okay. And it's not about, finding out and treating it all the points, and they just see if you're a good doctor, because as this is a basic level exam, right, for a junior doctor. So they just see whether you are a safe doctor and whether the patients will like you and things like that. So it's more
Mhm.
about that. And yeah, then we go to our differential diagnosis. So when we have an acute case, we need to rule out our red flags. So in data gathering, there's another section called red flags. So in this case, our initial red flag is glaucoma. So that's alarming, right? So we need to rule out, we need to ask some symptoms for that. Is there any halos around the light? How's your vision? Is there any blurriness or things like that? And you have any systemic changes like nausea, vomiting, or any joint pain, or any association muscle pain or things like that, to rule out other things. And then we can also ask about trauma to the eyes. So that's another important thing that we need to take care of. Is there any foreign object or trauma? Because that needs immediate removal, right? So that's also a red flag over there. So we need to concentrate about the red flags, and we can ask one or two differentials based on our time. So in these cases, it takes a lot of time to go through all this. So just a quick differential, maybe like conjunctivitis, whether she uses lens or any, is there any discharge or things like that, just to rule out the differential part. And yeah, that's the main point of our data gathering. So once we are done with that, we need to move to our examination, and that's where you ask to do a IOP and a general. First, we need to do a general examination, measuring her pulse and her BP, oxygen saturation, and things like that, just to make sure the patient is vitally stable. And then we go to our systemic examination about the eye. So yeah, we do our examination, and then we give our provisional diagnosis, stating that it's he suspect. So we always use a thing suspect, and we do not say that you do have this. It's just a way of, we need some more tests to confirm and things like that. So we say. And another thing is, we don't use medical words like you mentioned uveitis and things like that. So the patient doesn't understand that. So we just need to explain each and everything in a medical term. I mean, not in a medical term, in a layman's term. So we can tell the eye has many layers called sclera, UV, and things like that. So those layers get infected, so it becomes red, and that might also lead to something like that. So the only place where you use a medical term is in your diagnosis. So when you tell the patient that because of all these things, I suspect glaucoma. So we need to ask the patient, do you have any idea about glaucoma? Do you know what it is? Have you heard about it? And the patient says no. And then you explain that. So it is a condition in which the pressure builds up in your eye, and it can be alarming. It's life threatening. Like it can, also cause disturbance to your eye, and you can get a vision loss. So we need to inform the patient what it is and what it can cause if not treated rightly. So another main thing in data gathering is, in this case, the patient had was diagnosed with depression, and back pain. So as patient told, as Carol told, she had a depression and back pain, and she was taking amitriptyline for that. So we need to just explore a bit more about that. So since when you have been having it, how long have you been taking the medication? Because we need to be sure, right? Maybe she was prescribed it, but she may not have taken it. So we can't just assume that she would have taken it, and that would have caused the disease. So we need to be sure about that. How long have you been taking it? So have you had some things like this before, or is it the first time? And then once we make sure, we can use it in our diagnosis. So, and we can also, put a IPS point over there. We can ask her, are you feeling okay now? Are you feeling better now? So, do you need any support or things like that? As she told us that she was in depression, just, to make her comfortable and she's okay. So, we can just add points like that. That will help you in your IPS also. So, yeah, in management, so we made a diagnosis that it's glaucoma, and we need to admit her. So in glaucoma case, we are going to admit her, and once we admit her, the ophthalmologist will come and see. So the main management, what we should say is, I'm going to admit you now and do some tests, and the ophthalmologist will come and see you, and we'll start you on medications to reduce your pressure and things like that. And you did mention about giving an antiemetic and a painkiller to reduce her thing, so that was good. And then yeah. Another thing is, the patient might not know many things about glaucoma or whatever disease, right? So we also give some things called leaflets and pamphlets just for the patient to know more about it. So that is like a very easy way of getting marks. So once you mention those 2 points that you're educating the patient, so that adds up to your management marks. And a very important thing is safety netting. So safety netting is in whatever case it is, in all the cases you should make sure you cover these 2 points in the management part. You're educating the patient and the safety netting. In this case, when the patient mentioned to you that she came by driving and she wants to go back by driving, what you should have got is, we should have told that you advise her not to drive. It's not safe. That's good. But another point you can add is, you should notify DVLA. So there are some diseases which has to be notified, right? Like TIA, stroke, and things like that. So even this is an emergency. So we advise you not to drive as it's not safe. And you can also tell her to mention a notify DVLA. And another thing is, you did cover in data gathering, you should not miss ICE, which is idea, concerns, and expectations. So you covered that, so that was very good. So yeah, these are some things which gets marks easily or makes you lose marks easily. And yeah, in IPS, you did explain, you did do all those things, but you could be a bit more of patient-centered, and they do expect things like this in this exam. So the more sympathetic and empathetic we are, the patient likes us, and in turn the examiner likes us, and our marks just come. That's how this exam works. So we can just be more reassuring and making them comfortable. And if the patient says that, my eyes are glaring a bit and things like that, just a word like, maybe can we dim the lights around? So are you comfortable now? Do you need anything? So this goes in all our cases. So I think that would, bring our marks to a higher level. And yeah. In this case, there was another thing. The patient has a concern about taking care of her children because, she can't get admitted. So there was another main issue in this case. So for that, we can ask, is there anyone other than your husband who's there at home to take care of your kids? Or can you arrange something like a daycare or something for a bit? Is it possible? So we need to give her some options that she can think about and she can decide. But we can't force the patient. That's another most important thing is we can't say that you need to be you. We can just offer her support, and we need to, but tell her the risk factors and what happens if she doesn't get admitted. We need to convince the patient. So it should be more of like a convincing and offering support rather than like commanding or telling her that you need to admit, because we know the emergency, but we know how much she needs to. But in this PLAB 2, it's always about the patient's decision. So it's up to them. So we just need to implicate them, and we need to make them understand. So that's the thing about it. So I guess I covered everything. So do you have any doubts or?
Well, you explained it very well, and thank you very much. I took my notes.
Mm-hmm.
I need to work on my interpersonal skills actually.
Yeah. Because back, while we're working, we don't get much time to do all this, and
Yeah.
it's just like, yeah, what's happening? We need to solve the case and go to the next patient. But here in these exams, it's more of, that how we do to the patient, how we talk to the patient. So yeah, I guess that's a struggle initially for all of us because we're not used to so much of that back home. So yeah, maybe when you practice more cases, you'll eventually get to it.
Okay. Thank you very
Yeah.
much.
Yes, best wishes. Yeah.
Thank you very much.
Thank you
I'll
so
hand
much.
over to Dr. Rohit. Yeah.
Thank you so much. That was really good performance, Dr. Burfin. And like Dr. Niveta said, you need to focus more on data gathering because if you realize you basically asked a couple of questions and then you immediately moved on to manage examination and then you went back to ask more questions again. So that is what that tells the examiner is that you're very unstructured, right? So
Mhm.
there is a reason that there is a structure. You always do take history first, and then do you do the examination. Do you know why? Because
Sorry?
it's not, do you know why we always take history first before doing examination?
Well, to check, like, to focus on some areas more than others.
Like you don't get time to do everything, right? So you need to know
Yes.
what examination you need to do. So you have to make sure you ask everything that is needed in your history, and only when you're confident that you've asked everything and you have a provisional diagnosis, or even if you don't have a diagnosis, make sure you do your data gathering. So data gathering, keep a mnemonic, like keep a structure where you start with presenting complaint, history of presenting complaint, which is Socrates or Odipara. So if it's pain, it's Socrates. Any other symptoms, it's Odipara. So you quickly ask them. So how it works is you ask the presenting complaint, which the patient will tell you directly, and the next question should always be, can you tell me a bit more about it? So you should never ask closed question immediately after the first thing. Because if you start asking closed questions, it will just keep going in that direction
Mhm.
on what you are asking. So always make sure you start with an open question, keep it as open as possible, which is just tell me more. Just tell me a
Okay.
bit. Then once they tell you everything, you try to, as they are answering your, as they are giving that big long explanation, right? That time you need to start checking this Socrates off. So when they, for example, she said eye pain, and then yes, can you please tell me a bit more about it? And then she'll start like, it's on the right, it's on my right side. So you got sight, and then like from last 4 hours I've been having, you got onset, and then the patient stops, let's say. Now you know that you need to only start from C, which is character, radiation, any aggravating, relieving factors, and severity. So like that, always try to keep a checklist at the back of your head that you need to follow. Otherwise, it becomes very unstructured, and that shows the examiner that you don't have a structure in mind, because it's ultimately you're not talking to the, you're not doing this for the simulator, you're not doing this for the patient, you're doing this
Mhm.
for the examiner. Examiner is looking at you, trying to infer from what you're doing, right? So make sure you have to be very you need to somehow exaggerate these points where you are showing that you are systematic, you are showing that you are ruling out red flags, you're showing that you're sympathetic, because in normally you don't do that. It's this is a mind you, this is an exam where you have to act, because it's an acting, they are acting, you have to act as well, because that's the only way that they'll know that you're covering everything, because it's
Yeah.
ultimately when it comes down to, it's very subjective. If the examiner misses something, they'll mark you zero for that point. So always make sure that you're very clear in your head where you're showing the examiner. So always keep that in your head. So
Okay.
now going back to the structure. So presenting complaint, history of presenting complaint, you have Socrates Odipara, and then immediately you do differentials, right? So
Okay.
differentials. So even while you're doing the Socrates Odipara itself, you have differentials at the back of your head. Only
Yes.
then you do these questions, because that way you don't have to spend more time trying to rule out differentials. While you're asking these Socrates questions, you know a few things that you can rule out, right? So it
Mhm.
comes to practice. You need to keep practicing, because while you're studying something, it's very easy to think, okay, this is that, and yeah, you can answer MCQs very easily. But while talking, you need to have that in a
Yeah.
it just comes at the back of your head. So that only comes with practice. Try to do at least 4 or 5 cases every day, and
Mhm.
if you're just starting out, just at least one or two. Make sure that you're doing every day. That way, you just develop an internal clock, so you'll know when the time is, how much time has passed, even without looking at a timer eventually. So then we're talking about data gathering. So presenting complaint, history of presenting complaint, differential diagnosis. Now, after differential diagnosis, you have red flags. So red flags are something that is that needs to be done in every single station, even if you don't have time to do to rule out differentials. Immediately skip to the red flags, because red flags are basically you're ruling out the worst possible differential. That's all you're doing by asking the red flag, right? So
Mm-hmm.
you think of any patient you see, you think about what's the worst thing that can happen to this patient if any presentation you see. So first rule that out. So for example, this is a patient with eye pain and photophobia, and think about meningitis or GCA, anything that can immediately cause her to deteriorate. First rule those out, and then even if you don't have enough time, it's fine, because you've ruled out the worst possible outcome, and then you can move on to your examination. And you can, even if you give the wrong diagnosis in your management, it's fine, because you've shown the examiner that you are a safe doctor. All right.
Mm-hmm.
So now, yeah, going through the list again: presenting complaint, history of presenting complaint, differential diagnosis, red flags, and then you do a there's something called P-maftosa. It's basically it's a mnemonic for all the other questions that you need to ask in your history, which is past medical history, medication, allergy, family, travel, occupation, social, and alcohol. So you don't need to ask everything every time. You need to pick and choose which ones you need. But always remember, never forget past medical history, past medical history and medication history. These things always have to be asked, no matter what. And after that, you decide on your rest of the questions based on the scenario. So, for example, it's you think it might be an STI, you have to ask a sexual history, and you think it might be an infective disease, you have to ask a travel history, and you think this is a psychiatric condition, you have to ask psychosocial histories. And this psychosocial history is something, it's actually it's best if you ask in everything, because you'll never know when there are other factors that you might be missing, like whether the patient can go back home right now. Where do they go back if they leave the clinic? Do they have a home to go to? Like what if that person is a homeless person and you just send them back to the road? Always make sure you ask psychosocial history: where do they live, how is everything at home. Unless they specifically mention that they've given you a proper history, make sure you always ask about living situation and social support. Right, that's what psychosocial history is. And that's your history. And then you do your eyes, which is idf concerns expectation, and then only you go into the examination. So
Okay.
this way you have plenty of questions that you asked in the data gathering. That way you know what examination you need to do. So right now this is basically completely entirely eye related. So you know that you need to do you know that you need to do a general physical examination all the time, but you also know that what eye examination that you need to specifically mention, because they have different like clipboards with all the results written, and they only give you when you mention something. So if you say only general physics, if you just say examination, and they'll just probably only give you the general examination. They might not give you the eye examination findings. So always make sure you verbalize your examination, especially the special examinations. You always have to mention like what the results that you're expecting. So in this, by the time you finish your history taking, you kind of have an idea that it could be glaucoma only because of the amitriptyline. So now, since you have that, you can just quickly ask about the findings, because you don't need to do much examination to diagnose it again. So once you have that, and the way, then you have to reveal your diagnosis. So the revealing the diagnosis part, I noticed that it was a little too abrupt the way you mentioned. So instead of that, always try to keep a format on how you reveal your diagnosis, which is you tell them why you think what you're going to say it is. Instead of starting with your name of the diagnosis, start with your reasoning for the diagnosis and then tell your diagnosis. Right?
Okay.
So say that way you are basically summarizing the entire conversation you had with the patient and telling them what your decision making process in that, what's your how you came to that conclusion of that diagnosis, right?
Okay.
So and like Dr. Niveta said, always make sure to use the name of the diagnosis, the actual medical term, whatever diagnosis you're going to tell them, but everything else has to be said in layman terms. Right? That's the only place you use the medical jargon, which is giving the name of the diagnosis, and tell them and explain it in a simple format. All right.
Mhm.
Then you
Okay.
can, I'll refer you. So always, so referral doesn't really mean much to the patient at that point. So the patient, what they need to know is, see, referral is like you're just basically saying, I'm handing you over to another doctor. So that doesn't really help them much. They need to know what is going to happen. So what do they need to do now? Like, do they go home and wait for somebody to call them, or like do they get admitted right away? And this is GP clinic here in, right? GP surgery, right? So you have to tell them to go to the emergency room, because right
Okay.
now if you refer to the ophthalmologist, you don't know when they're going to see them,
Mm-hmm.
right? So always try to keep your think about what the urgency of the situation is, and you've identified that it's an emergency, but you still kept saying I'll refer you, right? Always that's a conflicting information. So referral means a lot of things. So you have immediate referral, you have 24-hour, 48-hour referral, you have 1 2 week referral, and then you have routine referral, which can take up to a year. So always mention what exactly the patient is going to have to do now, not what you have to do, right?
Okay.
Because that's not what they need to know. So tell them in terms of the patient's outcome, patient's disposition. So you need to tell them that so right now it's an emergency. Luckily, you are only having a slight blurring of vision, but if we let it, progress further, it might lead to complete loss of vision. And we do not want that to happen. So we need to send you to the emergency room as soon as possible, and do not drive. I'll call you an ambulance if nobody is there to pick you up, then so that you can immediately go. All right, always give all these information. So you need to tell them. You can't, you're not just sending them away like you go do this. You need to tell them everything. Like if you go out right now, you call someone. If somebody is not willing to come, then I'll send you an ambulance. So you give all the options, that way the patient knows what they need to do. All right.
Okay.
And so we tell every doctor, the last 2 minute bell is basically a warning for you to complete your management. All right. So whether you started your management very early in this, but most of the doctors, when they actually ask all the questions, they end up wasting a lot of time just taking data gathering. So the 2 minute bell serves as a warning for you to start your management, but I mean, like, to conclude your management. But you have to start your management at 4 minutes. Now, when you reach the 2 minute bell, and if you realize that you still haven't completed your management, you always make sure you cover 3 points, which are safety netting, follow up, leaflets, and pamphlets. All right. So safety netting, which is basically you're seeing what is the worst thing that can happen to this patient, and how you're going to prevent that from happening. Right. That's what safety netting is, which is basically you ask the red flags in your data gathering. So now you need to tell them that, saying if you feel like it's worsening, if you feel like you're feeling lightheaded, or if you feel like there's a sudden loss of vision or anything like that, make sure you immediately go to the emergency room. Don't wait. So just
Okay.
give them some sort of warning saying what is to come. So which is basically what's the worst thing that can happen to this patient, and just think about what the symptoms of that would be, and just tell that to the patient. All right, that is
Okay.
your safety netting. And follow up is something that you have to do for every patient. Even if you are sending them to another doctor, you always have to follow up with them again. You need to see them again to figure out what is happening with them, because what you're doing right now is basically you're writing a slip and sending them here, and you don't know if they are actually going to the specialist or if they're actually going to the emergency room. So always set up a follow-up appointment saying, I will see you again in a couple of weeks to see how you're doing after, whether they get admitted or discharged or anything. It doesn't matter to you. So make sure you tell them that I'll see you again in a couple of weeks to see what how you're doing. So I'll give you a follow up, because they can't get an appointment by themselves, right? So you have to give them a follow up, so that if they're fine, they won't come. It's fine. At least they'll have an appointment. So that is
Okay.
follow. And leaflets, pamphlets. So leaflets and pamphlets. So NHS has hundreds of leaflets for every single condition there is, every single treatment, every single alternative lifestyle change. Everything has a leaflet and pamphlet that they print. Physical ones, digital ones, everything is available. So they want you to give them, because that's a it's a big fight against misinformation that NHS is doing, and they want to make sure that the doctors are actually using these information and giving them to the patient. So make sure you mention leaflets or reading material or in that of that sort, somehow or the other in your management, saying I'll also give you some reading material or leaflets and pamphlets about acute glaucoma, so that you can understand more about this condition. All right. So these are the three things that you have to always cover.
Okay. Thank you very much.
All right. Thank you so much for joining. All the best.
Thank you. Thank you very much for your help.
All right. You have any doubts?
No, I took a lot of notes, so I'm gonna work on them. And as you said, I'm gonna work at least 3 to 4 patients per day to improve my interpersonal skills. It's quite a strange situation for us because I work in emergency and I have all my doctors under my eyes, under my hands. So it's
Yeah,
weird to imagine myself in a GP clinic. Yeah, that's
exactly.
why I couldn't accommodate. Yeah. So
Exactly.
I will work on them. Thank you very much for your feedback.
All right. So we'll send you a detailed feedback also. You'll
Okay.
also get video recording. So make sure you watch how you perform, because that's the best way to actually see how your interpersonal skills are. So make sure
Okay.
you watch the recording multiple times, at least the 8 minutes of the part, so you'll know what you'll identify things that you normally wouldn't identify. So make sure you watch the recording, and while you're practicing, also try to record it, or at least do it in front of a mirror or things like that.
Okay. Okay. Thank you very much.
All right. All right. Thank you, Dr. Niveta, Dr. Nevin.
All right.
Thank you, all of you.
Thank you, everybody, and good luck, Dr. Burfin. If anything, you can text in the group, and I'll be happy to help.
Okay. Thank you very much.
No worries. Have a good day.
You too. Bye
Thank
bye.
you. Best wishes, doctor.
Thank you.
Have a great day.
You too.
Please like and subscribe to Turing Med School. Good luck with your preparation.